the Innovation in Hematology series.
Okay, sir. Okay, sir.
Is it okay to start?
This meeting is being live. Sir.
Yes, sir, we can go live now. You can start.
Perfect. Hi, friends. It's a great opportunity for yet another episode of Innovation in Hematology, which Dr. Nikhil has been spearheading to impart the knowledge and share the best practices across the world. And today we have Dr. Anup Devasya, who's been a dear friend and a mentor to many in this country and abroad. But before we start, we have got Dr. Priyanshi, who's doing a commendable work in the field of myeloma at Fortis Noida as a lone warrior, and supported by Dr. Nikhil, who has been collecting the data and spearheading the myeloma research in this country. It's a great opportunity to learn in next 30-35 minutes. So please be ready with your own questions, your own problems, which continues to haunt you, where we can find the answers for that, so that patient can get benefited out of the latest cutting edge technology for myeloma survival. Dr. Nikhil has just published a Kaplan-Meier curve showing 93% survival, overall survival at 5 years. It's a commendable thing that we are increasingly seeing myeloma patients surviving longer. So, with this, welcome all to another episode of Innovation in Hematology, working together, collaborating for a brighter future. Over to Dr. Priyanshi.
Good evening, everyone. So, I would like to introduce our speaker as of today, Dr. Anup Devasya, who is also a mentor of mine as I was in residency in CMC Vellore. So, Anup sir has done his MD as well as his DM in CMC Vellore. He was a professor in CMC Vellore. He has a special interest in the disease, the multiple myeloma, as well as he has various contribution, various publication in other diseases as well. Sir has done his fellowship from the Princess Margaret Cancer Center. Thereafter, he is currently he's a professor in Ottawa, University of Ottawa, as a clinical hematologist, and currently in the program of plasma cell disorders as well. Sir has contributed into the disease with various publication and number of publications which are short to the introduction, starting from the pathophysiology of the disease to the management of the newly diagnosed multiple myeloma to the proteasomes inhibitors as well as high dose melphalan that can be used in autologous transplant and the disadvantages as well as various complications of the autologous transplant and new which the articles we will be discussing about the bispecifics in multiple myeloma. Thank you, sir. Thank you so much for your valuable time which you are giving us for understanding the disease and bispecific antibodies in multiple myeloma. Over to you, sir.
Thank you, Priyanshi. Thank you, Dr. Bhargava. Thank you, Nikhil. And thank you, entire team Fortis, for this wonderful opportunity. My role today is to give a brief overview about the use of bispecific antibodies in myeloma. And bispecific antibodies, is emerging as a promising therapy in this disease. These are my disclosures for the presentations. So this talk may contain details of several therapeutic agents that has not received regulatory approvals, and most of these slides are, taken from CCO, ASH, ASCO, EHA summary slides, and the IMS 2024 summary slides. So the outline of the talk is I'll give you a brief introduction about myeloma and therapy failure. Then we'll switch gears to bispecific antibodies. What are they? What is the efficacy of these agents in relapsed refractory myeloma? How do these agents compare with other agents? Bispecific antibodies can fail, so what are the resistance mechanisms and what are the strategies to overcome resistance? I will give a special mention to infections as the safety profile because that's the most common side effect with these agents. How do we compare T cell therapy options? And we have a lot of T cell therapy options. And so, is there any data to show how do we sequence these T cell therapy options in myeloma? So we know that multiple myeloma is a hematological malignancy characterized by clonal proliferation of monoclonal plasma cells. These plasma cells produce M protein or the paraprotein or the monoclonal protein, which in turn causes organ injuries in target organs, which we abbreviate as CRAB, which is hypercalcemia, renal failure, anemia, and bone disease. The treatment for myeloma follows two paradigms. If you're transplant eligible, you give induction, transplant, and maintenance. If you're transplant ineligible, you give a continuous therapy. And we know that myeloma is considered as a non-curable disease, or despite better options and advances, invariably all patients would relapse. and subsequently as myeloma would become a relapse refractory disease. The mechanisms underlying relapse is not well known, but there is clear data that relapse could be either because of the emergence of a new clone. We can see this as a different color here, or this could be because of a persistent disease which is not well controlled, which can later lead to a relapse uh, once the myeloma becomes refractory. Treatment options are many as the disease relapses, and these drugs are combined from different classes. And we have seen how the introduction of these drugs has impacted the outcomes and survival in myeloma. Myeloma, which was considered a dreadful disease, now is considered a chronic disease where patients live longer to die because of other reasons. At the same time, it has also been shown in many real world studies that there is significant attrition in the patient population who reports to further therapy lines. This means that as the patient progresses from one line to the next line, in each line, at least 15 to 35% of patients are lost. This also means that saving the best option for later aggressive relapse is not the best way. So you need to throw the best option available at the earliest. The treatment paradigm is changing. Now, daratumumab is coming as a recommended upfront option in myeloma, and combinations with daratumumab, either in the transplant eligible or the non-transplant eligible patients, have shown significant advances, and so daratumumab is moving to first line. Now, this also throws up unique challenges, because if you look at the outcomes of patients who have become refractory to multiple agents, like triple and penta refractory, you can see that once these patients are exposed and are refractory to three or four or five agents, their outcomes are poor. So moving daratumumab upfront throws a unique challenge that more patients will be dara refractory early, even at first relapse, and so we are left with very less options when these patients becomes refractory to three or four agents. So we need more than proteasome inhibitors, immunomodulators, anti-CD30 monoclonal antibodies, because these patients are getting sooner exposed to these agents. Now, T cell therapy or redirecting T cells to kill tumor cells was a major breakthrough in cancer that came up around 10 to 15 years ago. And this model was successfully shown in other malignancies, especially the B cell ALL. The immunotherapeutic options in myeloma are three. So we have the CAR T cell therapy, the antibody drug conjugates, and the bispecific antibodies. Antibody drug conjugates are fusion products of monoclonal antibody with a cytotoxic agent. The most common one used is the belantamab mafodotin, but the cytotoxic agent is the monomethyl auristatin F. CAR T cells are chimeric T cell product which is made with a viral vector created against a tumor antigen. And bispecific antibodies or BiTEs are the third class of T cell directed antibodies, which are again which are again utilizing your immune system. In the next 50 minutes, we will talk on the biology, mechanisms, efficacy, safety, and challenges in the use of bispecific antibodies in myeloma. Now, bispecific antibodies or bispecific T cell antibodies and bispecific T cell engagers or BiTEs, they're similar in function, but they're different in structure. Now, both these bispecific antibodies and BiTEs, they have two binding sites. One of them attaches to the target antigen, that is the plasma cell in case of multiple myeloma, whereas the other site targets the effector cell or the T cells, and the antigen that it binds is the CD3 cells. Bispecific antibodies, they are engineered constructs of a whole antibody. So these are dual targeting full
கொஞ்சம் சட்னியில்
antibodies.
உப்பு இல்லை.
Whereas BiTEs or the bispecific T cell engagers, these are recombinant proteins composed of two linked single chain fragments. So the bispecific antibodies compose the whole antibody, whereas BiTEs are the two FC fragments of the monoclonal antibody. As I said, the bispecific antibody, so in myeloma, the one fragment or the one side binds to the target plasma cell and the other one binds to the CD3 on the affected T cell. In myeloma, as I said, the target cell is a plasma cell, and on the plasma cell, you have multiple receptors. The most common three receptors that have been extensively studied for targeting are the BCMA, GPRC5D, and the FCRH5, and we shall discuss about each one of them in the next few slides. BCMA is also called as the B cell maturation antigen. This is the most extensively studied among these receptors. This antigen is expressed specifically on plasma cells and on myeloma cells. This antigen is not expressed on other tissues. The main role of BCMA is in B cell maturation and differentiation. It promotes myeloma cell growth. It causes chemotherapy resistance and also causes immunosuppression in bone marrow microenvironment. BCMA can be cleaved by an enzyme called gamma secretase, and this forms what is called a soluble BCMA. And you also have additional ligands for BCMA called as APRIL and BAF. APRIL is a proliferation inducing ligand, and BAF is a B cell activating factor. The next commonly studied plasma cell receptor is the G protein coupled receptor family C5 group 5 member, or the GPRC5D. The function of GPRC5D is not well known, but it is known that this is highly expressed on surface of malignant plasma cells. Along with the plasma cells, you can see that it is highly expressed on plasma cells, but this is also expressed on other tissues, especially the hard keratinized structures, which includes the hair follicle, the hair shaft, epithelial cells of the eccrine sweat glands, the nails, and the filiform papillae of the tongue. What is unique in what is unique for GPRC5D is the fact that GPRC5D expression is independent on BCMA expression, and so the GPRC5D is unaffected by BCMA loss. So if you have a patient who does not have a BCMA, you can still use GPRC5D as a target. The third most common one is the FC receptor homologue 5, or the FCRH5. Now, this is a surface membrane protein in the immunoglobulin superfamily, again expressed highly on plasma cells. And this expression is limited only to the B cell lineage. And the expression starts in the pre-B cells, and this is increased throughout the maturation to the terminal stages called as the plasma cell. And this is again highly expressed on malignant plasma cells. So these are the three receptors that have been extensively studied for targeting in multiple myeloma. So you can see that these bispecific antibodies target these three main targets on the plasma cell: the BCMA, FCRH5, and GPRC5D. So we have teclistamab, elranatamab, and linvoseltamab as bispecific antibodies targeting the BCMA. We have talquetamab targeting GPRC5D, and we have also have cevostamab that is targeting the FCRH5. Now, what happens is they link or they engage the T cells to the myeloma cell, and this synapse leads to T cell activation and differentiation. This leads to secretion of cytokines and perforins and granzymes from the T cells, which leads to myeloma cell death and apoptosis. So let's see what is the efficacy of these agents in the various as single agents in relapsed refractory myeloma. Teclistamab was studied in the Majestic 1 trial, and this study led to the approval of teclistamab in the European Union and also in US FDA in 2022. Teclistamab was given in the Majestic 1 trial to patients who were relapsed refractory myeloma after 4 prior lines of therapy, and these patients were refractory to PI, immunomodulatory agents, and anti-CD38 antibody. And this study shows that the response was amazing, with a 45% complete response and a stringent response, and a good stringent response of 30%. The median progression-free survival in these patients was 12.5 months, and 21.9 months was the overall survival in these patients. Looking at the safety data, the most common adverse effect on these patients were infections. The BCMA was the target, and you know that BCMA is expressed on all B cells, so the most common side effect was infection. What is interesting to know that CRS and ICANS were of low incidence. Only one patient had grade 3 CRS, and no patients had grades 4 or 5 CRS out of the total 72% CRS that was reported. All ICANS were grade 1 or grade 2, and all these ICANS responded to treatment. The second agent that was studied was the elranatamab, again a BCMA bispecific antibody, which was studied in the magnetism 3 trial. Again, similar patient group, myeloma refractory to all three lines of therapy. Vast majority of the patients were triple class refractory, and almost 25% of the patients had high risk cytogenetics. Elranatamab was given as a fixed dose schedule with step up dose and then a weekly schedule. And this again showed that on long term follow up, 61% had overall response rate, with CR and above documented in 36% of patients. MRD negativity was seen in 92% of evaluable patients, and again, this leads to a favorable PFS and median overall survival of 12 months. Now, this impressive result led to the approval of elranatamab in August 2023. Similar side effect profile of elranatamab, like in teclistamab. So again, the most common side effect was infection and cytopenia. CRS was seen in 57% of patients, but most of these patients had grade 1 CRS. And again, once the elranatamab was shifted from a weekly to a bi-weekly schedule, it was shown that the amount of grade 3 and grade 4 side effect decreased from 58.6% to 40%. Now, talquetamab is a bispecific antibody which targets a unique target called GPRC5D. Now, talquetamab was studied in two dose fashions. One is the zero point 0.4 milligram weekly and the zero point 0.8 milligram biweekly. There was also a group of patients who had prior exposure to T cell therapies. Most of these patients had triple class refractory disease or pentaclass refractory disease, and the median prior line of therapy was 5 to 6 lines of therapy. So, a group of heavily exposed and heavily pretreated patients. Looking at the efficacy, looking at the weekly group and the biweekly group, the overall response rate was around 70%. In patients who had received prior T cell redirecting therapy, the response rate was around 65%. Again, favorable PFS and overall survival, 35% 12-month PFS in the weekly group and 54% in the high dose but biweekly group. Again, significantly shown that the CRS, the grade 3 and above CRS was significantly less, and the ICANS was also less compared to the CAR T cell therapy. Infections were significantly low compared to the BCMA bispecific antibodies, because this doesn't target the BCMA and this targets only the GPRC5D. What was unique in this group of in this patient population was this on-target off-tumor side effect of talquetamab. I mentioned previously that there's a co-expression of GPRC5D on the keratinized epithelium, nail, and the tongue. So, unique side effects like skin toxicity, rash, oral toxicity, including dysgeusia, weight loss, nail toxicity, including dystrophies and ridging of nails, were seen in patients who were given talquetamab. Now, it was also seen that most of these side effects, except for weight reduction, reduced or improved as the patient continued on this treatment without any need for dose reduction with supportive treatment. Now, this slide summarizes the dosing schedule of teclistamab versus elranatamab versus talquetamab. Teclistamab is given in a step-up dosing day 1, day 4, and day 7. And then once the patient tolerates a step-up dose, it is given as a weekly dosing at 1.5 milligrams per kilogram. At the end of 6 months, if the patient attains a complete response or better, there is an option to make it to do bi-weekly schedule, but this is usually done after 6 months. Elranatamab is a fixed dose schedule, and the step-up dosing is 12 milligrams on day 1 and 22 milligrams on day 4. Once the patient clears the step-up dosing, it is given as a 76 milligram fixed dose weekly into 6 cycles. And if the patient achieves at least a partial response, you can shift the dosing schedule to bi-weekly at the end of 6 cycles. Talquetamab, as I said, is given in two dosing schedules, either as zero point 0.4 milligrams per kilogram weekly or zero point 0.8 milligrams per kilogram bi-weekly. Again, the step-up dosing is based on weight. It is day 1, day 4, and day 7. And once the patient clears the step-up dosing, depending upon the dose schedule that you decide, you can either give it as a weekly or a bi-weekly dose. The other agent that is now in clinical trial is the Vostamab. So this is a FcRH5 targeting bispecific antibody. Cevostamab was tested in patients exposed to multiple lines of therapy, including exposure to prior CAR T cells, antibody drug conjugates, and bispecific antibodies. Most of these patients, 85% of these patients, were triple class refractory, and 88% were refractory to the last line of therapy. And most of these patients had high risk cytogenetics in the study. This study showed that Cevostamab has a clinically high meaningful activity in heavily pre-treated relapsed refractory myeloma patients. The overall response rate increases with the target dose, so it was around 56.7%, and the median duration of response was 11.5 months. And looking at the safety profile, the incidence of infections was less with Cevostamab as it targets GPR, as it targets the CRCH5. The incidence of CRS was higher; it was around 90%, but it was all limited to grade 1 and grade 2. And cytopenia was also less severe compared to bispecific antibodies, the other bispecific antibodies. The updated data on Cevostamab was published later in 2022, and this looked at the efficacy of a prophylactic dose of a single dose of tocilizumab. So, in the study group of 75 patients, all these patients were given a single dose of tocilizumab prior to the administration of Cevostamab. And what came was that significant reduction in the CRS. You can see that the CRS decreased from 90% to 38.8% with a single dose of tocilizumab given as a pre-medication. And this reduction happened without any effect on the overall response rate. So it was found that the pre-administration of tocilizumab did not have a negative impact on the efficacy, and this data again throws light to the fact that tocilizumab is one thing that you can give to decrease the effect of CRS, and this can be done without affecting the efficacy of bispecific antibodies. Another unique finding or another significant finding that was noted in the Cevostamab study was 6 patients had to stop the Cevostamab because of intolerable side effect. And it was seen that all these 6 patients remained in remission in complete response for a median of 9 months. Out of the 6 patients, 5 relapsed later after 9 to 1 year. And out of the 6 patients who progressed, all 5 of these patients had good disease control when they were exposed back to Cevostamab. So this encouraging data again throws light to the option of a fixed duration therapy or drug holidays or treatment-free remission that is possible in myeloma. So these agents, which gives you durable remission rates, we still have an option of giving patients um, fixed duration with drug holidays, but these needs to be validated with longer follow-up in a large cohort of patients. Linvoseltamab is another BCMA bispecific antibodies, and this data was published recently. This is the Linker MM1 trial. Again, looking at the effect of these agents in heavily pretreated patients. This was again tested in 2 different dose cohorts, 50 milligrams and 200 milligrams. You can see that around 80% of more of these patients were triple class refractory, and 60% or above were quad refractory, and majority of these patients are penta-refractory. In the 50 milligram cohort, the overall response rate was 48%, the VGPR was 40%. In the 200 milligram cohort, the overall response rate was 71%, and the VGPR was 63%. You can see the ongoing responses in these patients on the Summers plot on the right side. And on the panel C down, we can see that patients who progressed when these patients were progressed at the 50 milligram dose, that their dosing was increased to 200 milligrams, and 6 out of these patients responded, and all these 6 patients achieved a VGPR. The safety signs in the Linker MM1 trial. So the most common adverse events were hematological. Grade 3 to 4 cytopenia was found in 30% of patients. CRS and ICANS were also seen, but these were mostly low-grade CRS and ICANS, and this was mostly seen after the initial step-up dosing, and most of these patients did not have further CRS or ICANS once they started tolerating the medicine. There are many bispecific antibodies that are being developed in the pipeline. and these are targeting these receptors BCMA and GPRC5D. These are being tested in many phase 1, phase 2 trials. Early results are encouraging. One of these bispecific antibodies by the name alnectamab was recently withdrawn from phase 3 clinical trial. And what is unique in bispecific antibodies is the less incidence of CRS compared to CAR T cell therapy. Now, how do these agents compare with CAR T cell therapy? Now, looking at data on ide-cel from the KARMA trial and cilta-cel from the CARTITUDE trial, if you look at the majestic and the magnetism data, you can see that the response rate of the bispecific agents are almost similar to the ide-cel and the cilta-cel. These are the CAR T-cell options in myeloma. But what is unique is the fact that CRS is significantly less in these patients. So bispecific antibodies give a comparable efficacy with CAR T cells, but with less incidence of CRS and ICANS. Now, this slide shows a comparison of the T cell redirected therapies with the other recently approved therapies which these patients would have received if they had no access to T cell directed therapy. You can see that there is a significant difference in outcomes and survival. On the left side, you can see the pomalidomide, dexamethasone, carfilzomib, dexamethasone, daratumumab, and selinexor based therapies. And these are the agents or therapies which these patients would have received if they had no access to bispecific antibodies. And you can see that there is a significant improvement if these patients received bispecific antibodies when comparing these to the other standard line of therapy. Now, despite these clear benefits, there is a subset of patients with unmet needs who does not respond well to bispecific antibodies. And these are patients who have extramedullary disease, who have high risk disease based on beta 2 microglobulin, high disease burden, high risk cytogenetics, and patients who are exposed to prior T cell redirection therapy. And so these patients group still remain as a group with clinically unmet need. So why do bispecific antibodies fail? So what are the resistance mechanisms that impair bispecific antibodies? Now, the response defying mechanisms could be related to the T cell intrinsic factors, which are innate to the immune system. Now, this could also be related to the bone marrow microenvironment and other immunosuppressive bone marrow effect, and also the effect of the target antigens that these bispecific antibodies target. You know that there is progressive immunoparesis in myeloma. Along with that, you can also have reduction or loss of BCMA expression. So the loss of BCMA or reduction of the BCMA can lead to resistance in multiple myeloma. The membrane-bound BCMA is a substrate for the enzyme gamma secretase, and this gamma secretase enzyme can cleave the BCMA from the surface of plasma cell, and this forms the soluble BCMA. This soluble BCMA can lead to resistance and decrease in the binding of the bispecific antibodies, leading to resistance. The levels of soluble BCMA after the gamma secretase cleaves the BCMA can is shown to have uh, uh, increase the risk of progression and correlates with adverse outcomes. The second possible mechanism is the target antigen loss of these bispecific of these receptors because of biallelic deletions and mutations, and this can affect the BCMA gene. So you can have the loss of these agents, which again can lead to the loss of these target agents. The bone marrow microenvironment plays a key role because you have the immunosuppressive effects of the T regulatory cells, and again the other immunosuppressive mechanisms because of proliferation of the bone marrow stromal cells and the bone marrow endothelial cells can lead to increased effect of these agents, and this can decrease the efficacy of the bispecific antibodies. The fourth mechanism is possibly very important because you can have T cell exhaustion and dysfunction because of continuous and persistent antigenic stimulation by these agents. So frequent exposure by these T cell directing agents can lead your T cells to exhaust, and this is again another concerning cause for failure of bispecific antibodies. There is again impact of checkpoint signaling as a major factor for dysfunction of bispecific antibodies. So, due to the release of the pro-inflammatory cytokines, the expression of the checkpoint ligands and the receptors, like the programmed death ligand or the PDL1 are upregulated in myeloma cells, and this can cause binding of the PDL1 on the T cells, leading to T cell anergy, causing T cell exhaustion, impaired cytokine production, and reduced target cell kill. So you have T cell factors, you have bone marrow directed factors, you have factors caused by T cell exhaustion, and again you have the other supportive mechanisms which can cause the resistance to bispecific antibodies. So how do you enhance efficacy? So you could combine bispecific antibodies with other agents. You could combine these agents with immunomodulators and cell mods. So you can see that once you combine these agents with other agents, you can increase the efficacy of agents. You can use it with daratumumab, you can use with cyclophosphamide, you can use checkpoint inhibitors to use these agents. So immunomodulators and these cell mode agents are known to potentiate the T cell responses, and there are many preclinical studies that show the synergistic activity of bispecific antibodies with cell modes. Now, when you combine these agents with other bispecific antibodies like the FcRH5 directed or the PDL1 directed agents, you are using two simultaneous antigens and you can overcome the resistance mechanisms. You could also use the anti-secretase and the secretase inhibitors called nirogacestat, which again can be used with bispecific antibodies. So these inhibit the gamma secretase inhibitors from cleaving the BCMA from the surface of plasma cells. And then you can also use cheap agents like cyclophosphamide because this will inhibit the T regulatory cells and again decrease the effect, potentiate the effect of bispecific antibodies. Now, these agents are being studied in combination with other agents. So there is the Majestic 2 trial, which looked at the efficacy of teclistamab with daratumumab and lenalidomide. The TRIM2 trial looked at the efficacy of talquetamab and daratumumab. The redirect trial looked at the teclistamab and talquetamab. The Majestic 2 study looked at the combination of teclistamab with the gamma secretase inhibitor. And then there is a Monumental 2 trial which looked at the talquetamab, the combination of talquetamab and pomalidomide. All these trials have been shown to have increased efficacy with good response rates and good progression-free survival in this group of heavily pre-treated patients. There was an update about the redirect TT1 trial. So this is a trial which combined teclistamab and talquetamab, and it was encouraging to see that there is exciting data in patients with relapsed refractory myeloma, in patients exclusively who had extramedullary disease. And this shows that we have a response rate as high as 50% in patients who have extramedullary disease when this teclistamab and talquetamab is combined. And now there is the second phase of the redirect trial, which is exclusively recruiting patients with extramedullary disease, looking to see if this combination can be a solution to this group of patients with extramedullary disease. There are a lot of upcoming and ongoing studies looking at various combinations of bispecific antibodies alone or in combinations. And there are also studies looking at moving the bispecific antibodies to earlier lines. So there is a Majestic 7, Magnetism 6, Majestic 2, and the Linger MM4 trial. This is looking at the use of bispecific antibodies as the upfront treatment option in newly diagnosed multiple myeloma. The Master 2 trial looks at the teclistamab as a consolidation option post-DARA RBD induction if the patient is MRD positive. And then there is a Majestic 4 and the Magnetism 7 studies looking at the effect of teclistamab and elranatamab respectively as a post-transplant consolidation mechanism. And the philosophy is that the immune system is more fresh if you use this, if these agents are used in early lines of therapy. And so these agents are being tested as earlier lines of therapy in multiple myeloma. The big concern about these agents is the high risk of infection. So I'm going to present a few data on what can be done to prevent infections. Now, teclistamab, elranatamab, and the other BCMA-directed bispecific antibodies have a substantial and durable anti-myeloma activity, but at the same time, they're associated with a high risk of infections. Now, this is because of the fact that BCMA is also expressed on the normal plasma cells, and the normal plasma cells are the one which produces the immunoglobulins that protect you from infections. And these are very much essential for the normal humoral response. So you can see that among the various trials, the risk of infections was as high as around 50 to 70%, and the risk of grade 3 and grade 4 infections was as high as 40 to 50%. On the right side, you can see how quickly the immunoglobulins are getting suppressed after these patients are started on bispecific antibodies. So it's a matter of few weeks to months that the patient completely becomes hypogammaglobulinemic once these patients are exposed to bispecific antibodies, especially the BCMA directed agents. A cohort of the Majestic study on 135 patients showed how these impair the B cell efficacy. You can also see that along with the monoclonal B cells, the polyclonal plasma cells are also decreased after exposure to bispecific antibodies. Now, this also leads to the impairment of effective vaccine responses. So these patients does not respond well to the vaccinations, and this has resulted in a high incidence of infections. And so, to prevent this, patients are advised to get all the necessary vaccinations before starting bispecific antibodies. And also, it is recommended that patients needs IVIG prophylaxis before starting bispecific antibodies if their IgG levels are very low. This study showed the impact of IVIG replacement. So there was one group where the patients were observed without IVIG, and the other group where the patients received primary prophylaxis with IVIG. And you can see that if the patient received IVIG prophylaxis, there was a tenfold reduction in the risk of infections. So the recommendation now is to start these patients on IVIG prophylaxis as an IV or a subcutaneous if the patient's IgG level is less than 400 milligrams per deciliter, even before these patients are started on T cell directing therapy. Now, you have to be very careful, especially when you deal with a patient with IgG myeloma, because the IgG levels can be quite high. But be sure that the IgG level that's very, very high is a monoclonal protein, and that's not the normally functioning IgG. So if you have an IgG myeloma, always subtract the M spike from the IgG, and what you get as the reminder is the patient's IgG that's functional. And if that remaining IgG is less than 400 milligrams per deciliter, these patients have to be started on immunoglobulin prophylaxis even before bispecific antibodies are started. So the recommendation for infection prophylaxis is to get all the outstanding vaccinations as early as possible, at least 2 weeks prior to starting therapy, because once these patients start therapy, these vaccinations may not be effective. These patients have to be screened for infections, especially hepatitis B reactivations. The recommendation now, as I said, is to give monthly IVIG treatment when the IgG is less than 400. And GCSF has to be considered in these patients once they develop severe neutropenia. But it's also recommended to avoid these agents in the first step-up phase because GCSF is a cytokine, and this can theoretically increase the risk of CRS. Antibacterial prophylaxis is recommended, not routinely recommended. This is based on physician discretion, but antiviral prophylaxis with acyclovir or valacyclovir is routinely recommended. Antifungal prophylaxis is again based on physician discretion, but PJP prophylaxis with Septra or pentamidine inhalation is recommended for all patients. So the first wave of T cell therapy gave us many options. So we have ide-cel, cilta-cel, belantamab, teclistamab, elranatamab, and talquetamab. So we have many options. How do we select and how do we sequence treatment? So an overview comparing antibody drug conjugates, bispecific antibodies, and CAR T cells. So I have listed the advantages and disadvantages of these agents. We know that there are no head to head comparisons between these three agents, but the most important advantage is the off shelf availability of bispecific antibodies. These are available to be used anytime. So, this is a unique advantage when a patient has high risk or a rapidly proliferating disease compared to CAR T cell, where you have a manufacturing time of 3 to 4 weeks, and that can actually be a problem when a patient has a rapidly progressive disease. The advantage of CAR T cell that it's a one and done therapy, and then the patient goes to a long-term remission. The problem with bispecific antibodies, it's a repeated treatment. It started weekly, then becomes bi-weekly, and probably we can change it to a monthly schedule once the um, patient is in response. Now, CAR T cell therapy has to be done in a fact accredited specialized centers, whereas now there are peripheral centers where the bispecific antibodies can be done after the patient is stepped up in an institutional setup. So bispecific antibodies can be given on an outpatient basis. Responses are similar across all these three agents, but then there is significantly decreased risk of CRS and ICANS with bispecific antibodies, and there is absolutely almost no risk of CRS with with the antibody drug conjugate. Infections are high with bispecific antibodies, and these patients have persistent and profound hypogammaglobulinemia because bispecific antibodies are given every weekly or bi-weekly. And then you always have the corneal toxicity with belantamab uh, when these agents are used, which is not seen in the other agents. So how do we sequence? So this is data from the Karma trial and the Cartitude trial, and also data from the real world data looking at the use of BCMA CAR-T again as a second option after the patient failed BCMA CAR-T. You can see that once you reuse a BCMA CAR-T after the patient fails the same agent, it's not of a much use. So the response rate is as low as 0 to 20%. So the BCMA CAR-T after BCMA CAR-T failure is not the best option. Now, what if a BCMA bispecific antibody use is used after a BCMA targeted CAR-T therapy fails? Again, this is data from Majestic trial and the real world data. You can see that if a patient fails a BCMA CAR T cell therapy and if the patient is used a BCMA bispecific antibody therapy after that, you may get an overall response rate of around 50 to 60%. So this shows that a bispecific antibodies can work even after a patient fails a BCMA CAR T. This also shows that among a BCMA bispecific and a BCMA CAR T therapy, if you have access to CAR T cell therapy, that should be the first one that has to be used because you still have the option of using bispecific antibodies later because sequencing of BCMA CAR T and bispecific antibody is better than using a bispecific antibody and then a CAR T cell therapy. Now, what happens if we change the targets? So if you change the target from a BCMA after failure to GPRC5D, the response is amazing. It's up to 75 to 80%. So it's even better responses because you are targeting a novel antigen and so this is again looking at the data of the GPRC5D CAR T cells in studies. So MCAR 109, the BMS GPRC5 CAR, and the ORI CAR. These are the CAR T cell options targeting GPRC5D. And then there is talquetamab, a single agent, the talquetamab and daratumumab in the TRIM2 trial, and again the talquetamab, dara, and pomalidomide in the subset of TRIM2 trial. All these have shown that if you change the target from BCMA to GPRC5D after BCMA failure, you still get better responses. Now, this is one interesting data that was presented at the last IMS looking at the cohort of patients who received talquetamab, daratumumab, and pomalidomide. You can see that these patients have a high overall response rate, even if they were exposed to bispecific antibody or CAR T cells. It was seen that the overall response rate was more than 80%, even if they had a previous exposure to bispecific antibody, with complete response in 58% and complete response of 70% if they had exposure to prior CAR T cell therapy. Now, what happens if we sequence BCMA after antibody drug conjugate failure? So these are patients who had prior received belantamab and they failed belantamab and then they subsequently received the other bispecific antibodies. Response was in the order of 60 to 70%, but responses were higher up to 75% when we changed the target from BCMA to the other agents. So some principles in sequencing are emerging. So it is clear that patients can still receive multiple immunotherapy. And among BCMA directed therapy, if you have all the options, CAR T cell therapy is the first preferred option because you still get a long time from the CAR T cell therapy and you can still sequence them with BCMA or other bispecific antibody, and that is comparatively better than using CAR T cell therapy after getting a bispecific antibody. So, switching targets is generally successful regardless of the modality, and it is now considered that the resistance is generally related to the tumor burden and not related to the target. So, if you have a primary refractory disease, it likely won't respond to others. So a BCMA CAR T failure and then a bispecific antibody is better. And this is highly better if you allow a favorable time of at least 6 months, because that will be the time for the T cells to mature, T cells to become functional after a failure of a bispecific antibody therapy. We still have challenges ahead. There is an entity, there is a class of patients who are now emerging. This is called primary refractoriness to T cell therapy. These are agents, these are patients who are primarily refractory to T cell therapy. So these patients still remain highly highly unrisk patients. There is still a lot of questions, a lot of uncertainty about optimal sequencing. We have some emerging data which is exciting. So we should have answers soon about how do we optimally sequence these agents. We still don't know the impact of time between T cell therapy because of constant antigenic stimulations. There is T cell exhaustion. So, what is the ideal time for the T cell to regenerate back so that the next line of immunosuppressive therapy, the immunomodulator therapy could act? So, we still have a lot of confusions. We still have a lot of uncertainty between the time. And again, despite all these, there remains this group who are highly uh, risky, the highly unfavorable group who has high risk cytogenetics, extramedullary disease, and who have plasma cell leukemia. So I would conclude this presentation saying that bispecific antibodies, either as single agents or in combinations, have shown very high overall response rate in patients who are heavily pretreated. Now, these agents are being moved into earlier lines of therapy, and these patients are being tested in combinations. There is clear data showing that bispecific antibodies could work even after CAR T cell failure. Switching the target from bispecific antibodies to from BCMA to GPRC5D or GPRC5D to BCMA is a viable option. Infections still remain a challenge, but this can be mitigated by the use of IVIG, antimicrobial prophylaxis, and vaccinations. And I feel that these bispecific antibodies are probable stepping stones to deep and durable responses in myeloma. And this could also open the doors to a possible option of treatment free periods, drug holidays, and possibly a cure in multiple myeloma. Again, we should wait and see for long term results. I would stop this presentation and I would open this for questions.
Thank you so much, sir, for the precise presentation, and it was very informative. Many of my doubts has been cleared now. So, but so certain questions are there. Some are there in the chat box as well. So, Dr. Nikhil has asked that which vaccines do you routinely administer prior to bispecifics?
Okay, so the routine vaccines that we usually recommend prior to bispecific is the flu shot, the influenza vaccine, and the Prevnar vaccine. And then if you have access to Shingrix, that's the killed the herpes vaccination. These three are the mandatory ones. The recommendation in US and Canada right now, where here is to get all these patients have to be on COVID vaccines every 6 months, even if they are on bispecific antibodies. Because what we have seen as the even if you get vaccine, the response may not be good because of the deficiency on the hypogammaglobulinemia because of these agents. So the vaccines recommended upfront is the pneumococcal vaccines, Prevnar and flu shot as early as possible, at least 2 weeks before these bispecific antibodies are given, and then with yearly flu shots as boosters. And then the recommendation by the CDC is COVID vaccines every 6 months, which I don't think is the option in India because here every patient's on bispecific antibodies or daratumumab gets COVID vaccines every 6 months.
Sure. So the another question is that teclistamab versus elranatamab, any comparative data is there?
No head-to-head comparison. It is completely based on physician discretion. The only advantage is that elranatamab is a fixed dose. The other one is a per kilogram body weight. The teclistamab needs three step-up doses, whereas elranatamab needs only two step-up doses. So it's completely upon the physician's preference. So there are no head-to-head comparison. Elranatamab has the additional side effect of having a rash. Teclistamab doesn't have it. Otherwise, in terms of infection, in terms of CRS, in terms of efficacy, there is nothing much of a difference between teclistamab versus elranatamab.
Sir, dosing regime for bispecific day 1, 4, or 7 versus 1, 3, 5. What is your practice, sir?
Tocilizumab, when we started treating patients with bispecific antibodies, when we used to give the step up as an inpatient, we never used to give tocilizumab as prophylaxis because these patients were inpatients and you could see and monitor these patients, and you would use this tocilizumab only if they develop CRS. We started using tocilizumab as prophylaxis when we switched the step up dosing from inpatient to outpatient. So now again, it's up to the physician. So we just use one dose of tocilizumab with the first step-up dose, and then
Yes.
subsequently don't use on the day 3 and day 5 or day 4 or day 7 unless the patient develops CRS. And we have seen that one dose of tocilizumab is actually enough, and a patient developing CRS or ICANS later is very, very less. So we don't use this 145 or 135. So I'm not sure if there is a comparison between 147 and 135.
Sir, you are in step-up doses. You are admitting the patient. You are treating them on OPD basis.
So we started with inpatients because we never knew how these patients are going to behave. But right now, vast majority of these patients are getting step-up dose as outpatients. So we have a dedicated area where the transplants, the autologous transplants are done as an outpatient. So one part of that side is used where these patients get outpatient step-up doses. But then these patients are advised to stay within 1 hour from the hospital. These patients should have a caregiver who is asked to do CRS monitoring and I score every 6 hours. So they are given, data on how to do it, and they are asked to call the hospital and report the CRS and the I score every six hours. And they are also reported to come to the hospital with the first spike of fever. So they come to the hospital, so they stay in close proximity for the first 1 week, and they are seen in the hospital even on the day between the step up doses. So they come to the hospital, get the step up dose, they go back, they come on day 2 for examination, they come on the next day, and again, it's up to the physician to decide whether these patients need a prophylactic tocilizumab or not. Prophylactic tocilizumab is usually given if the patient has a very high disease load, like a very high M protein or light chains with the, if you have extramedullary disease. But if you have a patient who has a very low disease load, it's completely up to the physician to decide whether you give tocilizumab or not.
Yes. So, do you use prophylactic IVIG in your practice?
So IVIG, the recommendation is to start IVIG if the IgG level is less than 400 milligrams per deciliter, even without any infection. So we start the patients on IVIG if the baseline is less than 400. Now, I said in IgG myeloma, the IgG can be very high. But then this IgG is mostly the monoclonal protein. So you have to subtract the M protein from the
From the
IgG. So if the IgG level is 800 and the M spike is very high, you have to subtract the M spike from the IgG and see what is the remainder. And if that remainder is less than 400,
and
the
we
recommendation is to start IVIG either as IV or subcutaneous, and then you can't stop it because you're going to give these agents continuously. So you continue it, and then most of these patients get IVIG as long as they get this bispecific antibodies.
Sir, I think you have answered this question, but still, just to clarify, if patients achieve a CR after 2 to 3 cycles, do you de-escalate treatment to bi-weekly or later to once monthly or 6 months? We have to give weekly at least.
So
At this time, sir.
not after 2 to 3 cycles. The original study gave the physician the freedom to downgrade to or de-escalate to bi-weekly if the patient achieved a complete response after 6 months.
After 6 months.
Now that was the protocol. So we just follow that. We are not trying to, make that early unless the patient develops a side effect like a severe infection. So if the patient develops an infection and then you want to space it out, it's reasonable. But then close monitoring is very essential. But that's not standard practice. The recommendation for the teclistamab was to give it till 6 months as a weekly dose, and then if the patient achieves complete response, to make it bi-weekly. Whereas for elranatamab, again, give it for 6 cycles. That is, one cycle is around 4 weeks, so closely around 4 to 5 months, and then make it bi-weekly. But the recommendation was at least a PR or a VGPR. You need not have to have a CR. So this is
Sure.
what was recommended in the Majestic and the Magnetism trial. That is what we follow as routine practice.
Sure. Sir, we had a patient. One of the doctors asked. We had a patient who developed atrial fibrillation with cardiogenic shock post first teclistamab dose. How often do you see cardiovascular side effects in your patients, and do you re-challenge them with teclistamab after a grade 3 event?
So it is rare, but then these agents are being used more. So there was a recent FDA publication about post-marketing where they showed that cardiovascular side effects, including cardiogenic shock, embolism, atrial fibrillation, are reported with bispecific antibodies. There was also a report about DIC happening with blinatumomab in ALL. So these are emerging side effects. There is no clear cut algorithm of how to restart it. What we usually follow is if the patient develops CRS or ICANS, we start with the first step up dose. So depending upon the severity of the disease, of the side effect, if the patient, if the physician still feels that the patient is able to tolerate or the patient needs the same agent, you could start from the lowest step up dose, start with 0.06 milligrams per kilogram, then watch the patient and then slowly step up the dose. But then you need to make sure that the heart is fine, the patient has been cleared by cardiology, and that the shock or the cardiogenic shock is completely improved. So there
Sure.
is no clear guidelines, but I would usually recommend that we start with the lowest step up dose,
Step up dose.
and then it's a trade off. You know that this is something which could potentially happen again. So, but then it's a complete trade off between side effect and efficacy.
Sir, one more question. We have had a patient who developed grade 3 ICANS post first dose of teclistamab. He was required steroids, anakinra, recovered after 72 hours. Can you share your experience in managing such patients who developed ICANS, like severe grades, grade 3 and
It's uncommon, and again, it is usually, I mean, found in patients who have a high disease burden. Um, I have not seen, I've seen grade 1 ICANS when these patients drop their I scores to 9 or 8 or 7, but not somebody who had a seizure or who has gone into coma. But then again, the treatment is dexamethasone, as you said. So start with high dose dexamethasone, start on anakinra. Again, once you have a grade 3 ICANS, there is always the concern of how do you challenge them on these agents. The overall data says that the risk of ICANS is less, and then this usually happens with a step up dose. So, again, depending upon the severity, I don't have any experience on a grade 3 ICANS after bispecific antibodies. The other potential thing that you could use is if you have done a CNS, you could see if the patient had myeloma in the left meninges, if the patient had CSF disease, and that was probably the reason why this patient had reduced risk of
right.
ICANS. But apart from that, you know, mm, the algorithm is still the same. If you have grade threes, you could decide whether you stop and no more bispecific antibody, or if you still feel that the patient could get it, go back to the lowest stepping dose and then slowly go up.
Sure, sir. So when do you do bone marrow examination MRD assessment for your patients on teclistamab? When
Standard practice, no MRDs for patients. Because you don't know what if the MRD becomes negative and if the MRD becomes positive, whether you increase the dose, you don't know, you don't have data. So as a standard practice, nobody does MRD um, for myeloma care routinely. I think some of the studies have done it at 6 months, and that was probably the recommendation that once you each 6 months, and if you are completely in complete response, you could de-escalate from weekly to 5 weekly. But
Sure.
on a standard line of therapy, a standard of care, we don't use MRTs routinely in clinical practice.
So when do you label someone as refractory to teclistamab?
I don't know. I mean, we still don't know the definition, but primary refractoriness is something that we see, and this is especially in patient who has a high disease burden, somebody who comes with a lot of extramedullary disease, who has a very high heavy chain load, who has a very high beta 2 microglobulin. But I don't think we still have a definition to say what is refractoriness to bispecific antibody. Obviously, these are patients who does not respond to bispecific antibodies, so who doesn't even achieve a stable disease or a PR, or who keep on progressing, or who have a very early who respond and then rapidly progresses within a period of few months. But I don't think we have a clear definition for refractoriness
Yeah,
to bispecific.
refractoriness. Sir, any experience in combining teclistamab with daratumab or pomalidomide or any other drugs, sir, you have used in your practice?
So the TRIM2 trial looked at the combination of DARA with talquetamab, and then talquetamab with DARA and pomalidomide. And similarly, there was also another study which looked at the combination of teclistamab and DARA to POM. Now, we don't use this because these are not approved for use in the clinical practice. So you can't, unless it's approved, we can't use it here. So this combination of teclistamab or talquetamab with daratumumab is not something that is approved, and so we don't use it in clinical practice. What we have used is we can add on cyclophosphamide. So there are patients who respond well to teclistamab, and then you see that their light chains or the paraprotein is slowly increasing. And there have been few instances where we add on oral cyclophosphamide because there is clear data that oral cyclophosphamide is something which inhibits the Treg cells, and that can potentiate the effect of the bispecific antibodies. So there are a few patients where we have added teclistamab and then again seen that the paraprotein slowly decreases. The other thing which we have tried is we also have access to pomalidomide on compassionate access. So pomalidomide is something that we could add. Again, getting data, seeing the data from the TRIM2 trial, again, this combination of talquetamab and pomalidomide gives you better responses because immunomodulators again enhances the potency of bispecific antibodies by suppressing the immunoparesis and the other inhibitory mechanisms of the growth pattern. So these are something which we could try, but then again, we don't try tech plus data or talquetamab plus data because these are not approved as standard combinations.
Sir, do you look at markers of T cell exhaustion in your routine clinical practice to predict patients who do not respond to teclistamab?
No, unless it is a clinical trial and the clinical trial has a basic science component where they are specifically looking at mutations or biallelic losses or resistance mechanisms or looking at exhaustion markers. On a standard practice, we don't look at exhaustion markers. These are not available. These tests are not available for routine use.
Sir, if patients have extensive disease burden, do you use any debulking strategy prior to bispecifics?
Now, that's a very good question because you know that you only have a limited immune system, and this limited immune system has to has to compete with a very high load of disease. So it is the philosophy is you need to decrease the disease burden as much as possible. So that's a reasonable mechanism. But the problem is what is the best treatment regimen that you would give to debulk the disease. So we have tried the combination of VD pace or VTD pace, but then this also comes at the risk of severe cytopenia, febrile neutropenia, and possible death because of the effect of VD pace. The other strategy that we have tried is to give hydrocyclophosphamide and dexamethasone. This is similar to the pre-induction that you would give for a high-risk Burkitt's lymphoma before they are started on the normal protocol. So
Yes.
there is definitely some role on debulking the disease because that reduces the disease burden and that would effectively, you know, that would probably, potentiate the effect of bispecific antibodies. But then we still don't know what is the ideal regimen.
Sure, sir.
It depends on practices, but then we again have to balance out the toxicity with these high dose agents because these are really intensive and cytotoxic regimens, and this can lead to grade 3, grade 4 cytopenia, and even wrong cytopenia, and the patient may not recover.
Sure, sir. Sir, in patients post BCMA CAR T failure, should BCMA expression be measured, soluble or surface BCMA, prior to teclistamab administration?
So they don't respond. I mean, once you start developing resistance to BCMA, it's unlikely that they respond soon. But then again, this is similar to the question you asked before, whether you look for T cell exhaustion marker. There are no standard labs, there are no standard assays which would measure the soluble BCMA or the other exhaustion markers. So standard of practice, you don't do it unless it is a research question, unless it is a trial.
Trial
We
basis.
don't do it as a standard practice to look for exhaustion markers or soluble BCMA. But this is the data is very clear. Once BCMA fails, once BCMA targeting fails, you need to give them some time because it's unlikely to show a longer response.
Sure, sir. Sir, sir. You have extensively practiced in India. In Vellore, we have seen many patients, sir. So, in Indian setting with cost constraint, do you think stopping teclistamab after 9 to 12 months would be feasible for good uh, PFS? Any ongoing trials in this regard?
There are trials going in this regard. So there are trials looking at um, not stopping, trying to increase the gap,
Increasing the gaps.
dosing, and then if they are still maintaining response, we could potentially stop it. Now, uh, this is probably from the belantamab data because in the Dream 7 and Dream 8 trial, when belantamab was combined with pomalidomide and daratumumab, belantamab has a serious corneal toxicity.
Yes, sir.
This is completely reversible, and some patients can take up to 3 to 6 months for the corneal toxicity to completely improve. So when belantamab was tested as a single agent, and when belantamab was given with pomalidomide and dexamethasone or with daratumumab, there was a subset of patients who got belantamab very infrequently, like once in 3 months, once in 6 months, or maybe once in 8 months, because of the corneal
Correct.
toxicity and the long wait for the corneal toxicity to
To
completely.
recover. Yes, sir.
It was really interesting and encouraging to find that despite having a big gap, most of these patients remained in deep response. So this is possible, but then we need to see it with the other agents, teclistamab. Essentially, it is BCMA that is targeted, so it could be possible. But then without solid, robust data, without long-term follow-up, without large number of patients, I don't think we can adapt it to practice. Again, if you have a side effect, you have to stop, you have to give gaps in between. But then just estimating that you could give it because these are deep and durable responses, I don't think it is possible. The other group that in which you should not try this is the high risk cytokine group because there maybe you can't stop it unless you have clear data saying you can stop it. So not standard, not it into practice. So I have no answer to that.
Sure, sir. Sir, how do you manage patients who develop recurrent cytopenias with teclistamab, sir?
GCSF is permitted except in the first stepping doses because GCSF is a cytokine, so there is a theoretical concern and risk of potentiating cytokine release syndrome. Like in HLH, you don't give
Yes, we don't
GCSF.
get it.
But then once the patient is on an established maintenance schedule, we give GCSF to make sure the counts are high. And then these patients also, once they develop into a long-term cytopenia, will be on antibiotic prophylaxis. So GCSF use is permitted, and that can be given, except for that the first week of
Step
step-up.
of doses. Okay, sir. Sir, a patient on talquetamab trial with loss of taste and significant weight loss, management and dose adjustment is required, sir. How to?
So most of those off-target side effects, except for weight loss, usually the severity decreases. And then the most distressing for the patient is the skin, the nail, and the dysgeusia
Yes, sir.
and the weight-related side effects. So we advise the patients to use a lot of moisturizing creams,
Sure.
and then they have to avoid hot showers because that can sometimes cause the skin to exfoliate. Some role about avoiding sensitive detergents and soaps, prolonged exposure to sun, prolonged exposure to water and detergents, topical steroids, some role for vitamin E, some role for biotin, etc. For the nails, we advise the patients to file the sharp end of the nail so that it doesn't get worse. We ask the patients to wear gloves when they work. So these are all supportive treatments.
Yes, sir.
Unless it's a grade 3, grade 4 side effect, we don't decrease the dose or stop treatment. For the GI related side effect, artificial saliva, frequent hydration, because this causes a lot of dry mouth. So artificial saliva, a lot of hydration is something that you could practice. There is also a role for artificial sweeteners because they completely lost the taste, and then that leads to decrease in the intake of food. So high protein, high calorie, but then small quantities, you know, fixed
Yes, sir.
split meal regimen rather than a increased amount of meat. So these are strategies that you could use. We also see some patients getting iron deficiency. We still don't know the mechanism why this process, probably because of the decreased
Intake of the food, yes, sir.
intake of food. So, supplementation of iron, supplementation of vitamins, artificial sweeteners, hydration in the mouth, oral, artificial salivary, saliva spray, or, these are possible things that you could try. And again, for the skin, it's moisturizing, petroleum jellies, topical steroids, antihistamines. Yeah, these are possible
Histamine.
things that you could try. And if the patient develops a severe symptom, then you can't give the agent again.
Sir, the last 18 question is, if patients have biochemical relapse post teclistamab, is second autologous transplant still an option?
Now, teclistamab is used as fourth or fifth line, right? I mean, you don't use teclistamab very early.
Yes, sir.
The utility of a transplant is best in the beginning and maybe at the first relapse if the patient had a long PFS after the first transplant.
Yes, sir.
I don't think an autologous transplant is going to be beneficial at the third or the fourth or the fifth relapse.
Sure,
So
sir.
I don't think that nobody would do an autologous transplant beyond the second relapse as a standard of practice. So I don't know if there is data. I don't think it's
Sure,
something
sir.
that's
It's a
practiced.
feasible option, sir. How commonly have you encountered cerebellar toxicity with bispecific, and sir, how do you manage?
So BCMA bispecific cerebellar toxicity is very, very rare. GPRC5D CAR T cell, the MCAR 109 trial, showed a cerebellar and vestibular toxicity as one side effect because you have GPRC5D expression in your inferior olivary nucleus. And similarly, there are few side reports of cerebellar toxicity after GPRC5D agents, especially I think the antibody drug conjugates that are being tested and tried. But there is a high incidence of cerebellar toxicity in the CAR T cell group, especially with cilta-cel. But this is extremely rare with bispecific antibodies.
Sir, last question is that, sir, if patients develop recurrent infections despite being on IVIG prophylaxis, would you consider increasing the dose or frequency to achieve higher IgG levels? What's your take, sir?
Yeah, so the standard dose is 400 milligrams per kilogram once every 28 days. But if the patient develops recurrent infections, we go up to 600 milligrams per kilogram IVIG. But then we also look at the IgG levels. I mean, if the IgG levels are not budding, then we go up to 600 and then to 800. Beyond 800, I don't think there is any validity. The other thing is we also have the option of subcutaneous IVIG. So rather than giving the full dose every month, subcutaneous IVIG is given every week. And studies have shown that if you give it as a subcutaneous dose, the steady state level is stable and more higher than giving IVIG every month. So because in IVIG every month the levels peak and then goes down, but the subcutaneous IVIG because it's in the subcutaneous tissue, it remains in the tissue for a long time, and the steady state level is higher for a longer time. So that is again another advantage of subcutaneous immunoglobulin. So these are the two things that we would do.
So I think that were all the questions. But I have, sir, my own one question. Sir, you have mentioned checkpoint inhibitors that can be used along with these bispecifics. So,
These
sir,
are in studies. These are in studies. These are in preclinical studies. These are not standard practice. So preclinical studies have shown that there is some synergy. There are some studies looking at combining. Some of the studies have not shown to be of any benefit, but then again, some studies looking at the combining teclistamab with BCMA bispecific with this PDL1 inhibitors or checkpoint inhibitors. But then this is not shown yet. This is not published yet. We still don't know the data, so it's not something that it's something that you can do next day. But we need to wait for the reports.
Sir, thank you so much, sir. Like in multiple myeloma, our all of our knowledge has grown one step ahead, sir, because of you. I mean, you have taught me enough, sir. I think, and you have taught many student, many people more. I guess. Thank you, sir. Thank you for answering all the questions. Sir, can you hear me?
Yeah, I can appear.
Yes, sir. I'm saying, sir, thank you for answering all the questions so in a very elaborate manner, sir. It was an excellent talk and a great Q&A session, sir. All the doctors are listening and they are appreciating it so much. And thank you so much. Thank you so much, sir, for your valuable time. And if possible, sir, next time, if any other advances are coming, I will request you one more time, sir, for the insightful lecture, sir. Thank you, sir. It will help all of us in patient management, in better patient management in India, sir, because we all are new to this particular bispecifics, and we have so many patients who does come with complications and have money constraints. So all the knowledge, sir, you have given us will help us a lot in patient management, sir. Thank you so much. Thank you so much, sir, for your
Perfect. Yeah.
valuable time.
Thank you so much for the opportunity. And then, yeah, hopefully we will meet again. Thanks.
Yes, sir. Sure. Thank you, sir. Okay, sir.